Hello and welcome to my presentation on simulating the impact of hospitals' capacity and social isolation to minimize the propagation of infectious diseases. I am Shaon Shuvo from the School of Computer Science at University of Windsor, Canada. Infectious diseases can spread from an infected person to a susceptible person through direct or indirect physical contact. Consequently, controlling the propagation of such types of diseases is difficult. Currently, the whole world is having trouble controlling an infection disease called COVID-19. However, we believe a propagation at the initial stage could help to control the disease propagation before it turns into a pandemic, and therefore this is the motivation of our research and which ultimately we got the research question that how to reduce these types of transmission, how to reduce the overall death ultimately, and finally how to reduce the duration of an outbreak. And to achieve these goals, what are the key parameters we need to consider? Two significant parameters could be social distancing, capacity of isolation bed in hospitals. Because social distancing and hospitals' capacity are considered among the most critical parameters to manage these types of conditions. The possible solutions could be estimating the disease propagation based on both of the parameters. And we can estimate the disease propagation either by using some mathematical modeling, and another option can be we can use agent-based simulation modeling. However, none of the existing mathematical disease propagations model can handle the complex scenarios based on both of the parameters, especially when you consider the parameters of social distancing. None of the existing mathematical model can be used to propagate the disease. Therefore, we choose agent-based simulation modeling. And using agent-based simulation model, we can create an artificial society, and we can simulate the impact of disease propagation based on some parameters values. Finally, we can observe the propagation pattern and other details. In fact, this is the snippet of our model here, as you can see, and we have used Refast Symphony to build and implement the simulation of the model. Refast Symphony is an open source agent-based simulation modeling platform that supports a variety of languages, and in our project we have used Java as the primary language. And this is the schematic diagram of our proposed model. As you can see, an susceptible agent can become an infected agent based on some infections parameters. And we'll discuss about those parameters shortly. And an infected agent can also be converted into either a recovered agent or a dead agent, depending on some recovery parameters and also depending on some conditions like whether the patient has been transferred to the hospitals or whether his immunity became less than the threshold value or not. And we have used continuous space to simulate the movement of agents. Grid cells are used to determine the nearby agents, because determining nearby agent is really important when you want to transform that susceptible agent into an infected agent, and also to find out the nearby hospitals when infected agents want to get the recovery. So we again the overall movement of all the agents and hospital's location every time it's quite random. Therefore, we ran simulation at least 5 times with fixed hospitals bed and social isolation starting day. After that, we collected the data of every simulation in CSV format. And finally, we calculated average number of infected, susceptible, and recovered agent, the and we represent them graphically from day 1 to day 2. And here are the summary of infection and recovery parameters. So one of the key parameters that we need to consider is the infection rate. And one thing you need to mention here that we try to model and moderately populated area. Therefore, we keep the infection rate in such a way that a maximum 2 susceptible agent per day can be infected by an infected agent, and based on some infection probabilities. So let's say in a grid, if there is an infected agent and there are S number of susceptible agent, the probability can be calculated based on that equation. And if the number of susceptible agent is 1, then this is almost 100% sure that the person is going to get infected. But if the number is more than 1, then we keep the equal probability 1 over S. And another infection parameter that we need to consider is infection period, and in that case we keep it 15 days. That simply means that within 15 days an infected people will be able to spread the infections. And also this is also important to mention that the person need to be transferred to the hospital within these 15 days. Otherwise, the person's immunity level will be below the threshold value 1, and the person will die. And another parameter is incubation period. And here the incubation period means that the period between exposure to an infection and the appearance of the first symptoms. So as our primary purpose is to see the number of recovery and deaths with a variable length of hospital size and social distancing activation days. So therefore we keep the incubation period very low to the models, and which is really just 1 day. So, and it is also essential to mention that we kept 50% of the population with critical immune conditions. And those people with those patients with critical immune condition, they need to be transferred to the hospital within 10 days of getting infected to get the recovery. And every time when you run the model, we need to initialize the model, and here for every time we keep some fixed values as the initial stage of the model. And initial stage can be considered as the first day of our simulation. And in first day, every time when we run the model, the number of infected agents are 2, number of susceptible agents are 500, and there is no recovered agent at the first day, neither any dead agent also in the first day. And we ran the whole simulation every time for 200 days. And as we mentioned that our main focus is to find out how isolation beds in hospitals and social isolations play the roles to reduce the outbreak and propagation, and also to reduce the deaths. Therefore, we keep these two values as the variables. So every time when we run a simulation, this value will be changed, and based on those values, we will observe the overall scenarios. And here one thing to mention that we keep the social isolation as a form of lockdown activation. And Another thing is here the location of hospitals and infected agents and the movement of susceptible agents are completely random. So this is our first three experiments that we ran, and in those experiments we kept activation delay fixed of 20 days. However, for all the experiments, every experiment we increased the number of hospitals bed. Let's say for experiment 1 we kept the hospital beds 10, for experiment 2 we kept it 30, and for experiment 3 we kept it 50 respectively. So this is the plot of experiment 1, plot for experiment 2, and for experiment 3. As it is observed that in all the cases the outbreak lasted actually more than 150 days at least. And in experiment 1 with 10 hospitals paid and lockdown activation delay as 20 days, the disease spread approximately to 90% of the population, and in fact to be more 95% to be more precise, and out of those 95% people, 40% of those patients are died. In experiment 2, when we increased the hospital's bed to 30 by keeping same lockdown activation delays, we found that the infection rates reduced, overall infections actually reduced to 72%, and death also reduced to around 22% of overall population. Again, in experiment 3, when we increased the hospital's bed to 50, then we have found that the total number of infections and deaths reduced quite significantly, as we can see in the plot. And the overall infections are over 15% of the people got infected, and when only 4% of the people died. Again, in the next three experiments, we reduced the lockdown activation delay from 20 days to 15 days, and we keep the similar number of hospitals bed for each of the experiments, like we have seen in the previous three experiments. However, in that case, we have observed that the the total outbreaks length reduced a bit, around 140 days, more than 140 days, and again the propagation of infections and deaths reduced almost with the increased number of beds. It reduced almost in similar fashion that we have seen in experiment 1, 2, and 3. Later, we reduced the lockdown activation delay to 10 days, and we kept the similar number of hospitals beds. For experiments, let's say for experiment 7 it is 10, and for 8 it is 30, and for 9 it is 50. As you can see in the pictures, it is observed that the overall every cases the infection rate reduced significantly in all the cases, irrespective of hospitals paid. However, the death rate also reduced significantly, which is less than 22% in all the cases. And again, if we mention about the total outbreak length, we have seen that the outbreak length of the outbreak also reduced to at least 125 days, which we have observed in the experiment 9. And later, in our last three experiments, we reduced the lockdown activation delay to 5 days. That means we started practicing social isolation from day 5, and therefore and also we keep the similar number of hospitals bed in every cases, and as we can see in all the plots, the total number of deaths and infections reduced quite significantly compared to all other experiment we have seen previously. And as we can see also that the total duration of the epidemics also reduced to just above 50% in all the cases, just above 50 days I should say in all the cases. So this is the summary of our all the experimented result, and this is the value. So as we mentioned already that with lockdown activation delay of 20 days, that means we have started practicing social isolation from day 20, and in that case we can see the length of epidemics is really high. Whenever we reduce the number of social activation, lockdown activation delay, we have seen that the overall length of duration reduced quite significantly, and also the overall infections, deaths also reduced quite significantly. Uh, However, one thing to mention is that whenever the uh, social isolation activation delay is more than 10 days, in that case we always prefer to increase the size of the hospital capacity so that we can reduce the total number of deaths, recovery, and infections, obviously. So, and one thing to mention here is that practically, since it is impossible to stop the movement of all the people in a society, therefore, after activating the lockdown scenario, we to make the model more realistic, we allowed the regular movement of 10 to 15% of people, especially those who need to go to the hospital on an emergency basis. And this is the result discussion from the whatever we have observed from previous experiments. We can summarize the result discussion as the overall, the lesser lockdown activation delay helps in a highest reduction in the infection rate. The rapid activation in social distancing also reduces the overall duration of an epidemic in a large number, which helps flatten the curves of death and overall infections curve. It has been observed that a hospital's capacity does not relate much with the duration of an epidemic. Instead, social isolation plays a vital role in determining the length of pandemic. However, increasing the capacity of hospitals can help to reduce total number of infections, deaths when lockdown activation delay is more than 10 days. And in conclusion, we can say the experimental study is the first agent-based simulation model with the best of our knowledge that suggests the link between the capacity of hospitals and social isolation activation delay to simulate the outbreak of a contagious disease. The outcomes of the disease propagation model indicates that the model can deal with various complex scenarios to generate an estimated prediction. The model is also capable of changing infection parameters, and the model can be used in the future to make decisions at the initial stage controlling an outbreak. One of the significant limitations of our model is that we only considered the lockdown scenario as the form of social isolation, and which can be extended further based on the degree of strictness to follow. We are currently working to collect data related to COVID-19. In the future, the model can be validated based on those data. And we would like to acknowledge that the research was supported by the Canadian Institute for Health Research. And here are some selective references that we have used in our paper. And thank you all for your patience hearing.